So it's the major story of the day as President Cyril Ramaphosa is expected to sign the controversial National Health Insurance Bill into law this afternoon. The draft legislation aims to create universal health care and has been over the 5 years in the making. Critics say that the plan is unaffordable and will collapse the private sector. Let's now bring into the conversation Professor Salim Abdool Karim, who is from the Center for the AIDS Program of Research in South Africa. We're also joined by the CEO of RHBUO, Quinton Zunga. Prof, good morning. Thank you so much for making time for us. Quinton, good morning as well. Prof, I'm going to start off with you. So after the president signs the bill at 2 o'clock, what happens?
I don't think much is going to happen because it's going to take many years before we can rectify the fundamental challenges we experience in the healthcare system that the NHI Bill aims to address. So, yeah, no fireworks or anything of that sort. But I think what today's signing is signaling is a commitment to addressing universal healthcare.
So many more years up until we can actually say that now NHI is functioning in South Africa. What happens in the meantime?
So at the moment, the way South Africa's healthcare system works, it's a residual care. In other words, if you can afford it, which a small proportion of our population can, you go to private healthcare. And for those who can't, you go to the public health system. So that dual system that runs parallel to each other, where you've got a private sector for those who can afford it and a public sector for those who can't, it's basically a form of, medical care apartheid. If you can afford, you get. If you can't afford, you get something much less. So the idea is to create a universal system where everybody has equal access. There are many challenges with doing that, and there are many ways in which one can try to do that. But NHI, as a funding mechanism, is one of the key ways most countries have tried to move in that direction from a split healthcare system that is both private and public.
Okay, let's now speak to Quinton. Quinton, good morning to you as well. Thank you so much for making time for us this morning. As RHBUO, which is black-owned and also looking at the market that you are targeting, what does this mean once the bill is signed into law and ready to be operational for that particular market, as well as RHBUO as an entity in the health sector?
Thank you very much, and good morning to all the viewers. For us, it's an exciting opportunity to start to implement. I understand the industry's hesitance, but everything needs a start. We need a starting line. If we keep the engagement on the bill without actually practical applications, we won't take it that far. So for us as a company, after the bill is signed, we're looking for partnerships with the government. We're looking for additional pilots. We're looking for implementation strategy and providing those services. Our belief is that the private funder model it's okay for a few people, but it's not okay for everyone, and also very exclusionary around the funder networks, which is really not a very transparent method. So there is criticism both sides, and I think where the government is at least a start.
Okay. So how is it going to work? Once the fund is now set up, this is now specifically speaking to Quinton about this. Once the fund is now set up and you provide a service to a patient, how then do you recoup the money from the fund?
So I guess that's the key thing. The fund is not practically set up yet. It's on paper now, and there needs to be set up. But what everybody needs to understand is that different provincial governments have been using private sector facility for a long time. So we think taking those model into a centralized port and gradually expanding the funding regime to include everyone over time is the way to do it. So I don't think it's a 100% NHI day one or nothing. I think you could start from 10%, 20%, and give yourself time to eliminate the problem. So I really think we, the private sector, should be 100% in support of a practical approach to implementation as opposed to try and spend more time just discussing the bill.
Yeah. Professor Karim, so Dr. Crisp says that currently government spends around 5,200 Rand per person per year in the public sector. And then we see in the private sector around 27,000 Rand per year is spent per person in the private sector. What will then happen to this particular disparity once NHI is fully operational?
So at its heart, an NHI aims to achieve two things. The first is it aims to achieve greater equity so that across the board, everybody can access a range of services that are within the NHI system. And the second is it aims to improve the efficiencies of the system by standardizing charging rates and standardizing the quality of care across the board. So it tries to do those two things. Right now, we have a situation where the private sector consumes a large amount of funding for a very small number of people. And that relates to a whole range of challenges that occur in the private healthcare system that was well described by the Competition Commission. So the goal is to get to that point. How you get there is a bigger challenge. And key step in all of this is to get to a point where healthcare services can become accredited, can become accepted as NHI services, and they contract into the fund. The moment a service contracts into the fund, they agree to working within the rules of the NHI, which would mean standardized pricing, standardized charging, and they remain private contractors. So they contract to the fund and they provide services to patients and to all patients equally, and then they charge for it and get reimbursed. So that's the basic system and how it's supposed to work. The challenge in South Africa is that we have really two big problems. The first is that we have a public health system that has many challenges, that many of them won't meet the criteria for being part of the NHI because they're inefficient, poorly managed, and so on. The second problem we have is that the ability of our systems to run an NHI is dependent on the economy. In other words, there has to be enough money being generated, enough people employed, enough people contributing to the tax base. And that's a challenge in South Africa because we have a very small tax base. So we're going to have to overcome those problems. That's not a reason for not moving to universal healthcare, but those are problems that need to be overcome as we move in that direction.
Yeah. I don't know, Prof, do you believe that the NHI would also at least try to reduce the medical legal claims that we've seen against the state? Is that a possibility at all?
Well, the big problem we have in the way in which the system is running at the moment is that we have in some places, we have health systems that are not being well run. And if they're not being well run, then they can't contract into the NHI. So if it's not well run, in other words, staff are being negligent or not caring for patients adequately, not billing properly, and that there are problems that patients are experiencing as a result of poor quality services, as we see very often in the Eastern Cape, and there's no good record keeping and so on, and then the state can't defend itself when it's taken to court. So that has to be part and parcel of remedying this problem, that you will have a situation where the individuals who feel they've had poor quality care can sue the state or sue the healthcare provider. That will continue. But what we need to move towards is a situation where that is minimized.
Yeah.
And NHI is not a solution to that. You know, good management, good healthcare services, caring healthcare professionals, that's what solves that.
Yeah. Quinton, for your company, you have shareholders. What do you say to your shareholders then when we have to determine the standardized approach that Professor Karim speaks about in terms of services and the fees relating to those services, whether the operations and so forth? But also on the other end, is there a possibility at all that we could see the overcrowding now moving from the public sector and to the private sector?
So the key thing for our shareholders is more optimal utilization of our private hospitals. We have private hospitals in 8 of the 9 provinces who are not at 100% occupancy. So the ability to bring in more people in those facilities is a massive opportunity. Obviously, currently we negotiate with each province separately for specific procedures with different tariffs. So if we're able to standardize that tariffs nationally, it makes it much simpler and much quicker to engage all the available accesses. We all know that different provincial governments have got waiting lists for oncology, for various orthopedic procedures. So our hope is that we can start with the backlogs. So before we go on to the simpler things, the common things, let's start where the backlogs is, and they are well known, they're documented. And if we standardize the pricing, then at a provincial level or at a national level, us, the providers of the physical infrastructure, can utilize this opportunity. So it's a massive opportunity, and we think that moving that backlog is part of moving the pressure from the public sector. So my view is a pragmatic and practical approach to NHI, which starts today, perhaps, if there's not too many legal battles, and which start with the overarching structure of the fund, adopting and pulling the existing partnerships with the private sector providers.
Yeah, but Quinton, with the current model with the provinces, is that the provinces will then speak to the hospital to say that, okay, we want to bring through patient X. But once NHI is in effect, doesn't it mean that any individual who lives within a certain radius of the hospital will be able to access that hospital and you won't turn them back?
It doesn't work that way precisely, because even in the current system, it's a referral base. I mean, even if you need to go to the primary center or an initial facility to get a first diagnosis to access tertiary facilities anyway. So I think currently there are already cases of patients that have been diagnosed that have got existing backlogs that everyone can actually rally around, right? Of course, everyone wants to just walk into any hospital for a headache. I guess that's what I was seeing. But the healthcare sector needs to work on a referral. And if we start with where the backlogs are and then start crowding in everybody else, that's a pragmatic solution which can start very quickly.
Okay, Professor Karim, last bite. What do you say to individuals who are saying that they will actually take this bill or the act once it's been signed on review and get the courts to decide on it?
I think that's a very important step. I would encourage that. We want to make sure that this is a huge initiative. It's a sea change in the way in which we're going to provide healthcare and organize healthcare. We need to make sure it's constitutional. We need to make sure that it passes legal muster. And for that reason, I believe that that's a good step. And we want to make sure that it's that every aspect of what is being planned, meets those requirements. At a very fundamental level, South Africa, like every other country, will never have enough money to provide, high quality, care like you get in the US or somewhere else to everybody. That's not practical. Almost no country in the world can do that. What you have to do is you have to ration care. You have to provide care to as many people as possible. And you have to provide it in a way that creates efficiency. In other words, that you're minimizing the wastage in the system. And that means you've got to get rid of corruption. You've got to get rid of the incompetence. You've got to run your healthcare service well. And in order to do that, you've got to make sure you employ good people. So you don't end up employing people who can't actually make this work, because then the NHI will not succeed. And we need to build trust in our government structures, which is sadly lacking at the moment. So all of those things need to be part and parcel of moving us forward in the direction of universal healthcare.
Prof, thank you so much for your time. That was Professor Salim Abdool Karim from the Center for the AIDS Program of Research in South Africa, and also the CEO of RHBUO, Quinton Zunga. Really appreciate your time.